And please do use the chat. If you have any questions or if you want to say hello, please put that in the chat. Without further ado, I will hand you over to our speakers to introduce themselves. So Andy, would you like to go first?
Yes, hello everybody. My name's Andi Orlowski. I'm a health economist and but also a student of the amazing Professor Alex Bottle, which I'm sure one of his worst students, and he'll explain later on why. But I'm the director of the Health Economics Unit, which is part of MLCSU.
Hi everyone. I suppose I'm Andy's supervisor, but I have I have many other roles. Particularly, yes, I'm a professor of medical statistics at Imperial College, London, and I'll be giving obviously a talk, and then Andy and I guess are going to have a chat about stuff afterwards.
Fantastic, thank you guys. I will stop sharing my screen and hand over to start with your presentation.
So let me share my screen. Hopefully you can all see my screen. Excellent. So I'm going to talk about variations on the theme of variation. In particular, when is variation not variation? Two things in particular. I'm going to go through how you measure variation badly and how you should do it better. And then some reflections on working with Dr. Foster, our long-time commercial partners, and particularly go through what do a hospital's mortality figures tell us about quality of care. Briefly, my unit is in the School of Public Health at Imperial College in London, and for many years we were part funded by a research grant from a commercial company called Dr. Foster Intelligence, now part of Telstra Health. And that was an interesting relationship because it was a mix of the what was originally a startup founded by two journalists. So you had the journalist attitude of wanting to get stuff out very fast and hoping it was more or less right, versus the academic approach of wanting to get out only what you knew was right, and it took as long as it took. So that was very interesting. And these days we're funded mostly by the National Institute of Health and Social Care research and other grants. And we have two main things that we do. So it's using routine data or electronic health records as well to produce and analyze measures for investigating variations in quality of care. I also have a strand around using this kind of data to evaluate various policies such as NICE guidelines or the introduction of vaccines. So the first big thing, when is a postcode lottery not a postcode lottery? So measuring variation is easy to do badly. Suppose you want to know how much your local GPs vary in terms of their use of spirometry for diagnosing chronic obstructive pulmonary disease. So this is a NICE guidelines that you should use this test to do so. Now, the proportion of COPD patients who get spirometry might range by practice from, let's say, 20% to 100%. And that might be reported, therefore, as a fivefold variation. And that sounds enormous, but it's actually pretty misleading. So we did this properly. I had a grant until recently to use CPRD data. So that's linked primary and secondary care data for 3 time periods. And for the middle cohort, so this is a slide for analysts out there. We assessed how much variation there was, and it was relatively small, as seen by interclass correlation coefficient and median odds ratio. And you saw that we had about 1 in 5 GP practices were either higher or lower than the average at 2 standard deviations. So there was some random, more than just random variation in there. But let's have a look at the funnel plot. So you may have seen these before. On the x-axis, you've got the number of COPD patients per practice, and up the side, we've got the proportion of patients receiving spirometry. And you've got a dotted line, horizontal line at about 88%. That's the national average. So most people get it, but not everyone. And you've got control limits, so dotted lines at 2 and 3 standard deviations. And you can see on the left, you've got a bunch of practices where everyone gets it, although the numbers are small, and a bunch of practices where nobody gets it, but again, numbers are tiny. But in the middle, you can see that there are some clear outliers here. Second example I want to give you got a lot of publicity. So if you remember in wave 1 of COVID, this got a lot of newspaper coverage, and this was from The Guardian. It was I think it was a Public Health England analysis that showed, it says, NHS data revealed huge variation in COVID death rates by hospital across England. And you can see there, it says the variation, it varies from 12.5% to 80%. And the whole article is, wasn't this appalling, isn't there, that there's all this much variation? And I knew immediately that that was just nonsense. So we set out to fix 2 very quite basic errors. And this article is in the BMJ Quality and Safety, where we assessed the mortality rates by hospital in the first wave. So first of all, let's look at the crude rates, death rates in the wave 1. So the range is about threefold if you just look at the crude rates, and 44% of hospitals had a high mortality at 2 standard deviations. So that's quite a lot. But then you do some quite basic adjusting for risk of age and sex and comorbidities and things, and that plummets down to 20% of hospitals being high at 2 standard deviations. And the ICC was just is pretty small. And in fact, to quote Monty Python's Meaning of Life, this is what we doctors call very, very small. So not a lot of variation, and we think that the risk adjustment was actually probably incomplete here because we just had routine data. Now here's the COVID, the funnel plot for COVID mortality, and you can see there are some outliers here, particularly as smaller ones. But this is a kind of funnel plot that you would see for death rates from stroke or AMI or hip fracture or just about anything. So there was nothing, I would say, unusual about COVID, about the variation in COVID death rates by hospital. Certainly a far cry from the headlines. And that brings me on to it's kind of my last example. So as a consultant, I run a 1-day workshop on statistical thinking for the public sector, and I've had clients from local authorities, charities, HMRC, MHRA, all sorts. And one of the bits on that course that generates a lot of discussion is this one, the classic so-called RAG rating, red, amber, green rating for key performance indicators. And I show them this slide, which is a couple of indicators published every year by local authority, where they give a target for each measure. They don't say where they get their targets from, they just pluck something out of the air. And they give you 3 years of figures, and they say green is when the performance got better from the previous year and target was achieved, and amber is when the performance got better but they didn't achieve it, or the performance got worse but they did achieve it, and then red is when the performance got worse and they missed the target. And so the first one, I always ask them, what do you think of these numbers? What do you think of green and amber rating in these numbers? And we discuss it, and I make the point that look, we don't know how many people we're talking about here. We don't know about the sample size. We don't know whether that their figure is statistically significantly different from either the year before or the target. And we're probably just looking at random variation here. And also, what is the difference between, let's say in the bottom one, 2.82 and 2.86? I mean, are those numbers meaningfully different? That would be what you would call clinical significance. I would argue that no, it's not. So if you're going to make decisions based on this, you've got to do a whole lot better, and this surprises a lot of people. So the second thing I want to go through is some history, but it's very relevant to measuring variation. And I was involved in different ways, and obviously not as causally, in 3 of the big NHS public inquiries we've had. First 2 was Bristol Royal Infirmary back in the 90s, and the second one was of course Harold Shipman back in the 2000s. In the first one, so this is one of the 2 surgeons who was struck off for really not doing very well for his operations on to tiny babies trying to fix their congenital heart defects. And we did an analysis of their data, and you can see here that the red and beige are Bristol's figures for these operations, and the other specialist centres are in blue. And you've got it shows the percentage of ops done and the death rate. So you can see that when the Bristol surgeons operated at a very young age, which is when you're supposed to do it, when everyone else was doing it, their patients all died. So they left it till the baby was much bigger at 11 months, hoping to do better. But everyone else was operating a much younger age group, which is when you're supposed to, and they did rather better. So this is okay, it's important for that, of course, but for the analysts amongst you, it's an interesting example of where you don't want to adjust for age, you want to stratify by age, because here these are elective procedures, and age at operation was under the control of the surgeon. And the final report concluded that Bristol was awash with data. This was back in the 90s, let alone now. But no one was really looking at the data. Of course, these days we definitely do look at the data. And I did a follow-up study in the BMJ that showed how things improved very dramatically after the 2 surgeons had been struck off. So that line at Bristol, that blue line with a really high mortality rate, that plummeted in 95 after they'd been struck off, and it's been improving since. But another important thing to mention here is that the total number of procedures, that's the black line, that stayed the same. So it wasn't that people were avoiding these high-risk procedures, they were just getting better at it. So just to note that you always want to look for unintended consequences of these things. Next up, Shipman, you remember Dr. Death. So I was tasked with finding the best statistical method to spot GP practices with high mortality rates. And I investigated the potential methods, and we published this in the Lancet. And the method that I found that was the best was something called a Q-sum chart. And here is the chart for the practices over time. And you can see that Shipman's line is in red. The higher the line, the higher the death rate, basically. And this shows that we would have spotted Shipman 2 years before he was finally caught if we'd been monitoring his rates. Of course, it turns out we would have flagged 12 other practices as having high mortality. They were all investigated, and obviously no further shipments were found. They were typically had a lot of care home residents, but interestingly, they all were known to the local authorities for problems with quality of care in other ways, but thankfully they weren't killing their patients. So we learned a couple of things from this. So one was that the administrative data were kind of good enough for monitoring outcomes. Second is that we think that, the SQ-sum method is the best way to detect the problems. And I'm working together with software engineer Dr. Foster, developed a national monitoring system for measuring mortality and some other indicators. So very briefly, how do we develop that monitoring system? Well, the first task is to process the data. So that is the patient level administrative data, or HES data, doing some basic cleaning and defining key things like what's an admission and what's an outcome. And then we needed to do some risk adjustment. So account for the fact that hospital patients are going to vary in terms of age, sex and things. And that was done with logistic regression. Then you set up the charts, and I have rules to spot when a hospital has a high mortality rate. And then you tell the hospital that their rates are high. So here's just an illustrative chart showing that basically, if the hospital's mortality is higher than expected, higher than predicted from the models, this chart is going to go steadily upwards. And at some point, it's like here and here, it's going to cross a threshold, at which point we would write to the chief exec of the hospitals, giving them these figures and telling them, look, you've got a high mortality rate. We think you might want to look into it. And we'll send a copy of the letter to the regulator, the CQC. And in 2007, we sent out a lot of letters to the same hospital. So this was quite soon after the system was set up. A lot of letters went the same way to the same hospital. So this is how we hope hospitals respond to the letters. So we hope that they would consider that there might be a problem with quality of care, not necessarily, but there might be. We think they should check their data. So, for example, I had a visit from the chief exec and the IT guy who's responsible for submitting data from a hospital who got one of these letters, a bit upset about it. And we went through their data, and it turns out their expected numbers of deaths were very low. And I looked at the data, and they didn't have any secondary diagnosis coding on there. For the last 6 months, they hadn't bothered to submit any, which meant that all their patients looked surprisingly well when actually they were quite sick. And that's what triggered the alarm. Now, the chief exec didn't know this, but the IT guy did know this. And I suspect that was a rather uncomfortable train journey back for that IT guy. Next, you should consider case mix. Are your patients actually sicker than the average? Every hospital claims that they are, but are they really? Then consider care pathways like transfers in and out of your hospital, things like that. And then only then should you actually try and review your processes and see what's going on. Mid Staffordshire did not do this. So as you will remember, Mid Staffs were trying to save money to become a foundation trust, and they took their eye off the ball in terms of quality of care. So when we wrote to them saying that you've got high mortality for all these patient groups, first thing they did was to say, oh, it's our data are rubbish. You can't trust our data. Then when it turns out that their data were actually okay, they then hired a rival group of academics to attack our methods. The only group of academics in the country, as far as we are aware, who don't believe that looking at mortality in hospital is worthwhile. And they brought out a report and a pretty dreadful paper in the BMJ attacking our methods, and we brought out a counter report, and it was all a bit unfortunate, because in this particular case, of course, we know mid-staffs had a lot of problems. This system has gone on to help a load of hospitals since, but we wanted more than just anecdotes, and we had plenty of those thanks to Dr. Foster. We wanted some proper evidence. So we got some money from the NIHR, and this report details what we did and what we found. Any of these reports and papers that I mentioned, I can, of course, send you afterwards if you drop me a line. These were the questions that we posed in this. We wanted to know primarily what was the cause of the alerts for high mortality. Why did these hospitals have high mortality? Was it because of dodgy data? Was it because their case mix? They really did have sicker patients than we were able to see given our administrative data, or was it quality of care? And how did they respond to getting the letters? The mid-staff's approach is a combination of ostrich and cobra. So sticking your head in the sand like an ostrich, and yet attacking the messenger like a cobra. And then did the mortality come back down after the alert when perhaps they fixed whatever the problem was? So what was the cause of these alerts? Well, we know the cause of the alerts because the CQC investigated about 3/4 of the alerts that we looked at, because we copied the CQC in on our letters. And encouragingly for the system, quality of care was cited as a factor in 70% of all of the investigations, particularly for the sepsis ones. The other 30% were due to a mixture of dodgy data and case mix. So 70% is pretty good hit rate. And if you look at whether the quality of care was sufficient to actually contribute to elevated mortality, that was about 1 in 4 of the alerts. So that's also not a bad hit rate. You'd like that to be better, but that's not bad. And what did the hospitals do? Well, usually they created an action plan to do something about it, particularly when they found quality of care as an issue. So that was all very encouraging. Just let someone in. So we learned from this that administrative data were good enough, not perfect, of course, but good enough to monitor patient outcomes in hospital. And we learned that these Q-sum alerts, this particular statistical methods, was pretty good actually at spotting quality of care issues. Now, if you had better data and if you're able to do better risk adjustment, then I think you would, of course, boost your signal. You would have less noise and a better signal. And our mortality monitoring system led to a number of changes in the way hospitals use performance information. All sorts of positive things that in terms of the change in their processes and staffing and things. And mortality rate did fall after these alerts, although trying to find why the mortality fell after the alerts actually is not straightforward, and I won't go into that. This monitoring system has been exported to other countries. So with other companies, it was exported to Holland, Italy, and the Netherlands. And in Ireland, they made a fairly close copy of it in what they call their National Audit of Hospital Mortality. I've been advisor for their health service executive for a while, and last year they asked me to lead a review of their system. And one of the things that came up from that review was the appropriate benchmark. So they were interested in, was a comparison between a small hospital in Waterford with a big hospital in Dublin really appropriate? Ireland obviously is it's got some big cities, but it's got a lot of rural places. So that was one of the things that they were interested in. Finally, I'll reflect on some of the directions I think performance of quality of care monitoring could go. So you would hope that in the future you're going to get more data integration. If you're able to bring in, physiology lab test results from hospitals, and you can get maybe patient-reported outcome measures or other such things in there as well, you get better risk adjustment, and you get perhaps more useful patient outcomes. And I think mortality and readmissions, these things are useful, but they're quite blunt in terms of being sensitive to quality of care. And you'd also be able to look much more at care processes rather than having to do paper-based audits. Some things I think outcome monitoring tools could and should do in the future, well, data quality checks, that should just be automated. Shouldn't have to trawl through that manually. They could perform useful subgroup analyses, like break down the mortality rate by age, by specialty, by day of the week. For instance, they should link to data on relevant processes, so processes of care. So you can go and do audit and do the next step. They can find care gaps, so things that should have been done for patients with a given condition or conditions along the whole pathway. So just as the NHS is often accused of working in silos, so its data is often really in silos. What you want, and what you can do increasingly with some local initiatives, is you want to be able to see the whole care pathway. So what happens in primary care through to hospitals, secondary and indeed tertiary care. You'd like to be able to see the whole pathway. If a patient dies on your hospital, it most definitely doesn't necessarily mean that it was your poor quality of care that led to that person's early death. And it should help generate a business case really for quality improvement options, because there are lots of ways you could potentially improve quality of care. They all cost time and resources. And so really the system should help you try and choose between them. Another big thing is they should find examples of other people who have battled with trying to improve door to needle times or whatever it is in hospitals, and be able, and what you learn from your quality improvement project should also be fed back into the system for other people to learn, because that's obviously such a big drawback with a big system like the NHS, is trying to hang on and make that learning available and accessible to people when they need it. And it also should close the feedback loop, so people should know you've done your quality improvement plan. Hopefully you'll have found things to improve, and you want to be able to tell people what you've done. And ultimately, of course, don't end up as the next mid-staffs. That is obviously what you want to avoid. So that's been a very quick run through of a couple of big areas. You can drop me a line on that email. I'm on Twitter, /X, and I'm also on LinkedIn. So come and find me there, and naturally I'll be happy to, chat about any of these things and more, and send you any papers or references that I've been talking about as we go along. So thanks everyone for your attention.
Thank you ever so much, Alex. And of course, just to remind people, I'm sure the papers he sends you will be his papers. So if you could cite them, that would be wonderful. And I'm making sure we kind of go from there. So I will ask a few questions. And of course, for those in the audience, feel free to join into it. Again, you can raise your hands or put them in the chat, you choose, as you kind of go through. And this is a great example that correlation is not causation, all because Alex was involved in those three horrible things. I'm sure he wasn't the cause of those three horrible things that we saw examples. So many of the people on the line, Alex, have been involved in things like pop health management, where at the moment we use variation a lot to better understand health inequalities or inequities, or just to be able to better understand the differences in outcomes or access for people across if it's across an entire ICS, so this may be 1 million plus people, to care provision. What can we learn from what you've just talked about today? So, and much of it may be related, but what are the things that we have to look out for when we're looking at variation data? So if it's kind of outcomes or access that that you've seen that could potentially trip us up when we're doing this work?
So you want to be sure about whether your data set is fit for purpose in terms of obviously the quality of the coding, and there are lots of coding traps and things that change in codes over time, which you may or may not know about, and they're not always obvious either. As I found in various projects to do with orthopedics and heart failure and all sorts of things. I mentioned care pathway, so always be a bit suspicious of, well, just aware of the limitations of a given metric that only covers part of the pathway. So a classic thing might be 30-day post-operative mortality for a given procedure, for instance. Now, if that's high, let's say, or even it's low, you don't necessarily know whether you don't know anything necessarily about the patient selection for those procedures and the timing of those procedures. Why did the surgeon choose to operate on that set of patients at that time, when potentially they might not have operated on another set of patients, or operated on them differently, or in a different using this operative method versus that operative method? Looking at cancer survival is kind of an obvious one. The surgeon is going to be interested in those short-term measures, but the population, of course, are going to be interested in maybe 5-year survival, etc. But even there, if you're looking at 5-year survival, as we know from lots of screening studies, where you've got biases coming in because the screening has led to early diagnosis of the cancer, earlier diagnosis of cancer than would have been the case without the screening. And you know that comparing populations or comparing ICSs, let's say, people are going to, even without the screening plan, national screening thing in place, some are going to pick up disease better than others. And that is inevitably going to potentially bias comparisons of 5-year survival and other things. So there are all sorts of traps to look out for.
And again, just in case there's a paper in this, Alex, is there something that we can share with the gang afterwards on what they could be looking for? Because we have this big issue that we have integrated care systems, we have some integrated data, but nearly all of the data that we tend to have access to is administrative data. So as you've said, it's things like SUS, and if we're very lucky, we may have some primary care data, which may be richer, but of course, there's wonderful variation, not just between ICSs, but between practices inside a practice. Even individual GPs prescribe may code differently depending on the time of day, how tired they are, and how they feel. What can we do to when we're looking at this data, this data that is collected ostensibly for administration purposes and payment? What do we have to be mindful of to make sure that we're getting the best out of this when we're looking for variation?
So, of course, we are relying on coded data, and we have to be aware of the financial incentives for coding to change. So, in secondary care, the big one was payment by results, but that's still with us. You've still got PBR tariffs these days that will incentivize this code versus that code. Anything that's where you've got a particular outcome measure like mortality, HSMR, or now you've got the SHME. Anything that's publicly reported is going to incentivize or potentially, incentivize a certain level of coding versus others to make you look good on that figure. And that kind of thing can change over time if you're not careful. Primary care, of course, we've had QoF for many years, which continues to incentivize the recording of some things and not others. And then you will presumably you'll have local service arrangements and local incentives where your CPs will be paid to do more of this and less of that, but you won't get that in the ICS next door, and so that again is going to potentially skew things. And if you've got primary care data, but if you've only got some, then and you want to look at sort of longitudinal measures, then you're always going to have to look at censoring. Loss to follow-up. Patients who are registered at a practice for a bit of time, then they move away and you lose them unless you've got national data and national linked data, which often you probably don't have. And you've got to try and assess the potential for that kind of bias on your analysis.
Yes. Well, if we've got time at the end, we'll remind everyone that Open Safely is now open for non-COVID stuff. I've put my application in, so I don't mind sharing it now in the hope that I'm front of the queue. If you could take a week or two to make sure that your better research projects don't beat mine, that'd be great. But one of the problems, Alex, that we've got then is we've got Marianne builds a wonderful algorithm that we see on a certain data set. So what you're saying basically is that those algorithms don't travel particularly well, or you'll have to readjust for how people are coding, how people are selecting patients, how people are doing these things. Is that, to make sure that algorithm that works so well in Mids and Lancs CSU for these trusts may not work so well in Dorset?
I mean, that's always going to be the case, even if there were no coding problems, potentially, because of population differences and that you've never got all the variables in your algorithm that you want. And maybe there's an important one that you're missing that affects your outcome in one region much more than in another region. But yeah, I mean, this is the same. This is a case with risk prediction algorithms everywhere. If you want some kind of recalibration of those algorithms, it is likely, and then you're going to have to keep an eye on them over time, and that's, for instance, why we started off with for Q risk, and then Q risk 2, and then Q risk 3, and because over time things change, and you've got to keep an eye on your calibration. Otherwise, particularly something like Q risk, which affects obviously the patient's chance of getting a statin or something, then changes in your threshold of your predicted risk is going to have big differences in what happens to people.
Yes, we'll go to Phil's question, but then I want to ask about risk strat, and I know that part of the problem we've seen with risk stratification is we're very good at identifying patients, but not very good at changing the outcomes of those patients, and that the work done by people like Bardsley and Garrett Lewis and all of those lot showing that things like PAR combined, etc., where we can identify people who come to hospital with about 80% accuracy. I haven't seen anything much more accurate than that, but again, they weren't using very many codes. I can't remember. I think PAR was only 7 or 8 sus codes, and still pretty accurate, but we're not changing the outcomes. Phil, over to you.
Thanks, Andy. It's not so much a question, I suppose, more of a sort of a statement, an observation from my previous life in medical sales, which was largely ruled by HRG coding for a big portion of it in orthopedics. And I remember having discussions with one particular orthopedic theatre, and they were losing about 150,000 in lost payments a month through incorrect coding. And I think it links into like the morbidity and mortality data, that surgeons would pick the worst comorbidity of that particular patient to code first to get the extra uplift in the payment, when it may or may not have been the most relevant comorbidity for that particular procedure, or they would just code everything as, say, a simple hip procedure, even though they were doing vastly different things from case to case. So yeah, I think, and it links into what Rachel put before she had to leave, unfortunately, about she spent a lot of time in HRG design and coding, and it's sad to see that it's always blamed the data's fault when it's highlighting quality of care and mortality issues. And it's, I think the problem with the whole coding thing was that nobody really understood it. Especially the surgeons who have been told to do it, they just didn't grasp it fully, I don't think.
And the question of who does the coding in hospital varies a lot by hospital, but even within the same hospital. So in some departments, some hospitals, you've got the clinical codes embedded closely with the medical teams.
Yeah.
And they can check easily what procedure did you do? Was this actually a hip replacement with cement, or was it actually a hybrid, or whatever? And did Mrs. Jones actually have heart failure, or was she just a bit breathless and it's query heart failure, in which case we can't put it down, or etc. Whereas other places, they're in the basement, and they do whatever, and the clinicians on the ground have got no clue how HRG, and don't know what an HRG is. I mean, why would they?
No. It was all siloed as well, wasn't it? The coders and the surgeons would never meet. Their notes would get sent down to them, and the coders would just put whatever was on the notes into the system, and there would be no communication. So it goes back to sharing information a bit better, doesn't it?
Well, there's a famous case of upcoding in North Italy that remember that the hospital kept reporting to the government all these complex cases because they got higher payments. But they also did a wonderful study that was published in a big journal, which also had all the details of the patients and their comorbidities. And the Department of Health looked at this. They were caught out, and I can't remember, 2 or 3 of them were sacked for clearly gaming the system over numbers of years. But they were hoisted on their own petard, or whatever it's called. This idea of that they shared this paper looking at the comorbidities of the real comorbidities. And to your point, Phil, there was a new stent device that you could put in that cost £5,000 a pop. The code, if you've got the coding wrong, you've got something like a payment of, like £500 or £1,000 versus something that was £1,000 plus the stent at £6,000. So if you were to up code incorrectly, you could get a lot of money for this, or if you were to get it wrong, you could lose a lot of money as you're kind of going through. But
I had similar with foot and ankle surgeons who did the same procedure week in, week out, and it always used a bone graft, but they always forgot to code for the bone graft. And when I pointed it out, they said, "You realise you're losing 40% of what you could get for that procedure every day."
There's also another case with a lovely paper about dentists. Tooth extraction is like £50 if it's surgery, if there's some bone attached. So of course there was always bone attached to the tooth. Anyway, let's no, that's why he's driving a Porsche and I can't afford a car. Anyway, so that's but Alex, one of the things that you mentioned about is the communication of this, and so lots of the guys on the line and who will be listening, we're told to look into this variation, and often or we're using the data to better analyze how care is delivered or the hospitals operating. When the news isn't good news, do you have any advice on how we communicate this, the variation or those changes? Even if it's as simple as your red, amber, green is useless, you should be using something better than that. Or if we've done some analysis that shows that there may be issues with care, what advice can you share with people to communicate this through to others in the healthcare system?
So that's an important question. So there were you give two different examples there, and I think that each needs a different message. So in the case like I showed, where KPIs are just presented badly, and decisions therefore are based on those KPIs, and they're changed over time, are going to be the wrong ones. Then the message needs to be not just, oh my God, what an idiot you are! Don't you know anything about basic statistics and random variation? But to propose a better system and point out why you should be looking for testing for random variation and looking for changes that are clinically meaningful. In medicine, there's the concept of minimum clinically important difference, MCID, which is not a tiny decimal place different. It's something that hopefully the local whoever's acting on this would agree that we are only going to change policy if our performance on this measure goes up or goes down by X amount, by 5%, 10%, whatever it is. Otherwise, it's no point. It's a waste of time. And to give some idea of, you could avoid chasing your tail and wasting resources for these 20 indicators if you do it this way and focus on these 5 and propose an alternative and a much better way of doing it that saves them resources and work, and is more likely to pick up genuine issues. And then the other one was kind of like giving bad news. If you have to tell them that the mortality rate or whatever it is high, if you can give them some context there that says that helps them understand where it is that they need to look for the problem, as that could be potentially sub-analyses. So on the Dr. Foster system, we would often suggest things like looking at day of the week variation to see if there was a problem at the weekends rather than during the week. And sometimes one example I remember was mortality after AAA surgery, so abdominal aortic aneurysm at a given trust. And they found that their mortality was only higher at the weekend and not during the week. And they looked at the rotors and found that actually there was a lack of senior support at a weekend, lack of senior cover. And so it was the juniors who trying to do these tricky operations without support, and so they changed the rotor and the mortality fell. So offering some kind of these kind of sub-analyses and suggestions for improvement is always people don't like to hear problems, they like to hear solutions. So that's a kind of thing always goes down well.
No, thank you. There's this whole bit around data literacy for senior management, and I know people have been talking about this a long time. And again, with the huge changes that are happening in analytics, and I think since COVID, everyone's suddenly remembered how incredibly important we are, and we may still be in a shit part of the estate, but they might talk to us now rather than just ignore us as usual. And of course, with this absolute fascination with AI and machine learning, which may just be the fact that they're bundling statistics and statistical models into a single bit of software that can run lots and lots of things. There's this kind of profound kind of interest and scrutiny behind this. This is the answer to so many problems that we've seen, according to things like the long-term workforce plan and beyond. So is there a group that's going around at the moment? You say that you're doing your work on kind of statistics for the public sector. Is there anyone going around helping people better understand this? I know that there's the wonderful Sam Riley with Plot the Dots and statistical process control. Who else is kind of helping kind of raise data literacy with decision makers? Who can who can you point people towards to help support the gang?
I've not looked recently. I probably ought to ought to know what kind of organisations are, if any, mind you, are doing this at the moment. And I don't know of any who are doing what I'm doing. I mean, I was approached by organisation called Understanding Modern Gov to run this course, and they run a whole load of other courses for the public sector. And I think one is on specifically on performance information. So that's not just for the public sector. I think that will probably private companies will go to anybody who uses KPIs of any kind. There's one they do a bunch of courses, but anything that's specifically aimed at chief execs, MD, medical directors, or etc., as chiefs of nursing, board members, I don't know, I'm not aware of stuff. That's not to say there isn't any, and there really does need to be. I remember one hospital came to us worried that their HSMR was 85 and were trying to get it up to 100, and we had to say no, 85 is good, that's lower than average, it's not a process measure, and you don't want to go at it to go up to 100. It's just like so there's a long way to go.
Cool. No, thank you guys. And of course I can't speak to you without mentioning impactability, this horrible made up word around risk stratification. We kind of alluded to it before, this idea that we're great at identifying people, and now with, as I say, things like causal inference and some of the other machine learning techniques, you can much more quickly identify potentially people at risk of an event and what may be driving those causes, and to help you, rather than spending the year I did doing a boring lit review because somehow it makes me a better analyst. I'm not sure if it does, but doing this
skill.
Yeah, it is a skill, not a skill that I want, but it's I'm kind of going through that element, but now being able to do that much more quickly by using the data to feed you in the right direction. Again, not saying that there isn't a place for literature reviews, but what can we do to, and I think what you've alluded to throughout all of your talk is that we're doing this analysis to make things better, to have a bigger impact on the population, and we don't have to use that horrible impactability word. But what tips have you got to try and, when we do analysis, to make sure that we're changing an outcome, or at the very least an output for patients or care processes? What do we have to think about?
I suppose by mentioning the word impactability, you're thinking about the likelihood of succeeding. So the likelihood of let's say a given GP doing spirometry more when thinking about COPD, or doing a BNP blood test more often when they're considering heart failure, or whatever it might be. And one thing I think is, I kind of mentioned it briefly, was the business case for quality improvement. So not every quality improvement effort is going to be, well, it's going to be successful, or it's going to be cost effective. Some are going to cost a lot more than others, and some will not be as successful as others, not because they're necessarily it's a bad thing, bad idea, but because it's been tried out and on the maybe in the wrong way, or on the wrong patients. If you want to get people to lose weight, people age, I mean, okay, stereotype, people aged over 70 to lose weight, you don't send them an app to help them track their weight. That is not going to, blatantly not going to help them lose weight. But so there has to be just has to be better tailoring of any QI proposal, or any proposal to fill those gaps in care that I mentioned earlier, with an acknowledgement of patient characteristics. And we often don't have very good data on that. The patent activation measure, for example, the PAM score, it is not collected very much. I think that in Northwest London they collected that for a bit for some patients, and then they didn't renew the license, so we don't even have that anymore on the data. But that's just one way of trying to classify patients into how engaged they are with their care, and therefore how likely they are to use self-care measures as opposed to rely on their healthcare team to tell them what to do, what to eat, when to take the pills, or whatever.
Yeah, we haven't spoken much about the wider determinants of health and how powerful those socioeconomic data and those bits can be in better understanding our patients to be able to make those decisions today. But a huge thank you, Alex. We're coming up to the end of our time. As always, it's lovely to see you. But I'm very lucky I get to speak to you whenever I want. Well, I say whenever I want, whenever you're free. And it's not like I can bust it, but it's always fascinating and always lovely to hear about the work. I say thank you for everyone who joined. If you do have some questions that you want to ask Alex that you didn't want to ask in a group, we will share Alex's details with you. And again, if you've got any kind of questions about the wonderful work he's done on variation and again looking at quality of care and beyond, please let us know and we can connect you with Alex and make sure that we share them more broadly. And we'll make sure that this video or recording is available for you to be able to have a look afterwards. But as always, Alex, not that I'm biased, but obviously you're my very favourite Alex Bottle in the whole wide world. You're by far the most handsome professor in medical statistics that I know. And please give me a good grade on my PhD. I know it doesn't work like that, but you know what I mean.
I'll make sure I find you some really, really nice and tame examiners.
Yes, that's it. Yeah, and stop asking for all of these boring lit reviews and other things. You asking us to be thorough and do stuff like that. That's not what I signed up for.
Academic rigor.
Yeah, Jesus Christ. Who wants to do that stuff?
Here's about that.
Can I not just do a bit of maths and have a bit of fun? That's what I wanted. But a huge thank you, Alex, for your time today. Thank you for everyone joining. And as I say, we'll share Alex's details as we go forward from there. But again, thank you very much, Alex.
You're welcome.
Cheerio, everybody.
Thank you, folks.
All right.
Bye-bye.